Hi. The role of LC-PUFA fats in perinatal nutrition is a major focus of our research group at SAMRI. As a neonatologist, my interest in this issue is also keen, given my involvement with preterm and very preterm infants. The LC-PUFAs, these are EPA, eicosapentaenoic acid, and DHA, docosahexaenoic acid, in the N3 series, and arachidonic acid AA in the N6 series, have important roles to play in tissue development, in organogenesis, and in function, and many functions. So they have important roles to play in the central nervous system, particularly with vision. They're involved in immune modulation, and they have important pro-inflammatory processes, but also processes via which inflammation is resolved. The effect of the LC-PUFAs are mediated by molecules called oxalipins. These produce a whole range of families of molecules, such as the prostaglandins, the leukotrienes, resolvins, protectins, maresmins, and so on. If a deficiency of LC-PUFAs did occur, then correcting those deficiencies in the preterm infant particularly has the potential perhaps to improve neurodevelopment, to improve vision, to modulate the immune system, and perhaps even to favourably modify some of the inflammatory morbidities that are seen in the newborn infant, particularly the preterm infant. Now, for the purposes of this talk, I'm going to start from around 2000 or so, by which time it had been decided that term and preterm formula should be supplemented with DHA to about 0.3 of total fat. This is around the average of total fat found in breast milk. At 150 to 160 mils per kilo per day, this would equate to an intake of around just above 15 milligram per kilogram per day. The studies behind that involved the sentinel observations of Martin Uringer and her team regarding the essential nature of omega-3 fats, comparative studies between breastfed babies who were getting DHA from the breast milk, and at the time, formula-fed babies who had no source of DHA. So looking at levels in red cells, looking at differences in DQ scores, looking at tissue accumulation of DHA, and finally studies that looked at supplementation showing benefit in both development and vision. These were the facts, if you like, behind the decision to supplement with DHA. But what about the preterm infant? If we look at the preterm infant growing in utero, we know that the fetal accretion rate of DHA is about 45 milligram per kilogram per day. We know that the intake at 150 to 160 milligram per day, be it breast milk or formula, is going to be about 15 to 20 milligram per day, which is less than half the accretion rate, even if it was all absorbed. We know that endogenous production of DHA is limited. And for this reason, preterm babies, especially the very preterm babies, are really set up for DHA and, in fact, AA deficiency. So preterm babies have low levels of DHA at birth because DHA levels in fetal plasma rise through the third trimester. And after birth, their low intake leads to a further decrease in plasma DHA and red cell DHA levels. So what about adding AA and DHA to babies? The first study that really looked at that was the Norwegian study from Henriksen. I apologise for the spelling error there. This study looked at babies less than 1,500 grams, and they were breastfed babies, and their breast milk was supplemented with DHA at 32 milligrams and arachidonic acid at 31 milligrams. This was started at the end of the first week and continued until discharge. Babies in the supplemented group had higher problem-solving scores on ages and stages at 6 months and better recognition memory on visual testing at 6 months. A subset of this cohort, about 70% of them, were followed through in subsequent studies. So at 20 months of age, the supplemented group had better attention, but by 8 years of age, no difference in development could be detected. And at the same time, MRI-based studies showed no difference in brain macrostructure. We were very interested in the idea of supplementing with DHA with a pilot study that showed significant benefits with vision. In our study, we decided to leverage off the fact that breast milk DHA content is a direct reflection of maternal DHA intake. So if you wanted to raise DHA in breast milk up from the average of about 0.3, you simply have to supplement mother with enough DHA. So in addition to dosing studies that have shown this, the same thing applies to milk around the world. The DHA content of milks is determined by the mother's dietary intake of DHA. Interestingly, arachidonic acid content of breast milk is fixed at about 0.5% and is independent of maternal diet. So in a way, the DHA variation in breast milk gives us a natural variation with which to test differences in DHA intake. So this formed the basis of our DINO trial. This was a large randomized controlled trial, which was designed with a primary outcome of neurodevelopment at 18 months corrected age. As I mentioned earlier, a preliminary subgroup of this study were involved in detailed visual assessment studies. So the trial involved babies less than 33 weeks, about 650 of them. High dose group the higher dose group got increased amounts of DHA by taking breast milk with mothers supplemented with DHA. And if there wasn't enough breast milk, then they were provided with formula with 1% DHA. The standard DHA group, the mothers were supplemented with soy, and they had access to a formula with 0.3% DHA. So what did the study show? Remember, the primary outcome was DQ, as determined by the Bailey's 2 at 18 months corrected age. And these results are all corrected for gestational age, sex, maternal education, and birth order. So overall, higher intake of DHA intake was associated with a modest increase in DQ, which did not reach clinical significance. However, in girls consuming high-dose DHA, there was a significant increase in their DQ of 4.5 points. And in addition, less girls consuming a high-dose DHA had DQs less than 70 or less than 85. In babies weighing less than 1,250 grams, there was also a tendency to a higher DQ, but again, this did not reach significance. However, in this group, higher DHA intake was associated with a reduced incidence of DQ less than 85. With respect to secondary analysis, visual acuity was better at 4 months of age with high-dose DHA, but we saw no effect on growth, ROP, neck, IVH, or sepsis. But unexpectedly, we saw a trend to a lower rate of BPD in the overall group and a significant reduction in the incidence of BPD in the group less than 1,250 grams. Now, this was exciting. It seemed to indicate that high-dose DHA produced a developmental benefit, particularly in the smaller babies, and it may actually reduce the incidence of BPD. both of which outcomes would be clinically significant and of value. For this reason, we decided to design a study to more sensitively look at these issues. And in so doing, we had another look at the DINO study and realised that there were some issues related to delivering DHA in breast milk. The first issue is that there's considerable biological variability in the amount of DHA you see in breast milk with maternal supplementation. And this ranged from problems such as difficulties with the mothers taking the capsules required to increase DHA, but even in those mothers who are fully compliant, we still saw quite a lot of biological noise in the levels achieved. The other issue related to the use of breast milk to deliver DHA is obviously the fact that the baby is only going to get the full intended dose when they're on full feeds. If we're thinking about the extremely low birth weight or low gestational age group, then we're well aware of the fact that that may not occur for some time. Therefore, for our new study, we decided that we would develop an oral supplement that we could give from the onset of enteral feeding. So in conjunction with industry, we developed a microencapsulated aqueous emulsion of DHA and a control emulsion involving soy oil. And as you can see here, increasing doses of DHA, this is a pilot study, gave increasing levels of DHA. And we decided on the basis of this pilot study that we'd aim for about 60 milligram per kilogram per day in order to prevent the initial drop that you see by 7 days and to achieve an increase in the level of DHA that matches what happens in utero. You can also see on this slide that arachidonic acid levels decrease to about 10 to 15% of their baseline levels. So this study was the NERO study. It's a large RCT. It involved 13 centres in Australia, New Zealand, and a single centre in Singapore. It involved babies less than 29 weeks. And as you can see, there are 1,273 babies in this study, so a big study. The intervention was 60 milligram per kilogram per day of DHA. The control was a soy emulsion with no DHA. And the outcome of interest for the design of this study was BPD, as defined by the physiological definition from the NICHD. Obviously, we're very interested in looking at the neurodevelopment of these babies, but this study was developed to look at BPD. Now, an important add-on to this study was that we decided to make use of technology that had been recently developed by Bob Gibson and Leah Gurr in our laboratories. This is the PUFA coat dry blood spot. This, if you like, is a Guthrie card for lipids. It allows you to collect, stabilise and store a blood sample for later analysis for fatty acids, for long-chain polyunsaturated fatty acids, and for quite an extensive array of oxylipins. So we have samples of blood from each of the 1,273 babies in the NERO study at baseline and at 36 weeks gestation, which is when the intervention ceased. So what did we see? Well, as I'm sure everyone knows, somewhat unexpectedly and a little unhappily, we found that high DHA intake was associated with an increased rather than decreased rate of BPD, with this increase of about 5% and a bit being significant. This is clearly not what we were expecting. It's clearly pretty tight with such a large study group. And so, like all good results, once they're there, they're there. You can't really forget about them. With respect to other problems of preterm neonates, we saw no signal of an effect with respect to ROP, IVH, sepsis, NEC, or length of stay. At around the time that the DINO trial was being conducted and towards its later stages, a Canadian team led by Isabelle Mark were conducting a parallel study using DHA supplementation via the mother and looking at bronchopulmonary dysplasia as an outcome. In this study, mothers took 1,200 milligrams of DHA compared with the 800 milligrams in DINO, with the placebo in this study involving a blend of corn and soy oil. Again, the babies of interest were those less than 29 weeks, and the original design aimed for 400 babies in each group. Because of the results of the DINO trial, and based on a interim analysis, the results of MOBYDick, the trial was terminated at 60% enrolment. What did they find? Again, they found that high-dose DHA intake was associated with an increase in the incidence of BPD. With respect to other outcomes, again, sepsis, NEC, and ROP, there was no suggestion of involvement or effect. There was a significant increase in the incidence of NEC in the control group, or a reduction of the incidence in NEC in the, sorry, not NEC, I'm talking about intraventricular hemorrhage, severe intraventricular hemorrhage. You can see there a higher incidence in the control group and a reduced incidence in the DHA group. I think this is unlikely to be a causal relationship because IVH is really a problem that's declared itself by day 3 to 4. And yet the intervention in this study didn't start until about that time. And of course, full feeding, which would have been required to get the full dose, would have taken another week or so. So I don't think this is likely to be causal. I think if you do a quick meta-analysis with the data from the DINO trial, you find that the IVH sort of falls out as something related to DHA. So I guess the question is, or the observation is, that high-dose DHA seems to be associated with an increased rate of BPD. And obviously the question is, well, why is that so? I think some clue to that comes from this study by Camelia Martin and her team in Boston. This study is a preclinical study. It uses a mouse hyperoxia model of BPD. And as you can see in the upper panels there, the mouse raised in room air, the mouse exposed to a period of hyperoxia. You can see this quite distorted lung on the upper right with reduced alveolar numbers and marked thickening of the septal walls. Remember that that thickening is the barrier over which gas exchange occurs. If you take that model and add resolvin D1, now resolvin D1 is a metabolite of DHA, you can see that there is marked resolution or reduction in the septal thickness. While if you take the model and add lipoxin A4, and lipoxin A4 is an arachidonic acid oxylipin, you can see that there's an improvement in the quality of alveolarization. And in the bottom right there, if you add both, you end up with a reasonably respectable looking lung. Now, I guess with this information and knowing the results of DINO and MOBYDick, it could be argued that high-dose DHA reduced access or displaced arachidonic acid, such as to inhibit the production of lipoxin A4. Now, that's an interesting idea. I think that we do have the oxylipin profiles of all the babies in DINO, and we are going to be able to explore this issue at some stage. But I think it just raises the question about possible importance of arachidonic acid in this situation. So just to digress a moment, because remember that one of the other things that DINO showed was neurodevelopmental improvements. We followed that cohort along out till age 7. doing a number of studies along the way in subgroups. And at year 7, we followed 92% of the original cohort. And as you can see, we saw no benefit with respect to language at 26 months, no difference with respect to behaviour at 3 to 5 years, nothing with respect to visual processing at 7 years. And at 7 years, with a very extensive battery of testing, we found no benefits in IQ, attention, executive function, behaviour, educational progress, and no effect by sex or birth weight, as was suggested in DINO. The only thing we did find was that girls had poorer executive functions as reported by parents, but not as determined by objective testing. We're not sure of the significance of that observation, but it holds true. The follow-up of the NERO group at 5 years is recently completed, and I understand that the MOBYDick developmental assessment at 2 years is also recently completed. And I imagine that we'll see the results of those testings towards the end of this year. So what other studies have looked at high dose DHA? Mexican studies from Mariela Banabe Garcia and her team looked at an intervention of high dose DHA, 75 milligram per kilogram per day, given for only 14 days from the onset of feeding. And this is in babies between 1,000 and 1,500 grams, so a somewhat larger group of babies than the very preterm babies in DINO and NERO and MOBYDick. What they showed in their study in 2019 was a reduction in grade 3 ROP. However, they didn't see a reduction in the overall incidence of ROP, and there was no difference in the need to intervene between the two groups, which rather raises questions about the clinical relevance of the finding. In a more recent publication, in a larger group, but with the same intervention, they reported a reduction in the incidence of NEC. Now, it's difficult to reconcile these with results with the results of DINO and NERO and MOBYDick, where we saw no evidence or signal of an impact on either of these outcomes. Finally, and somewhat more excitedly, I think a recent study published in February of this year looked at the effect of enteral LC-PUFA supplement involving both DHA and arachidonic acid on severe retinopathy of prematurity. This is a Swedish study from Hellstrom et al. It has a reasonable basic science support in that we know that resolvin D1 inhibits pathological retinal neovascularization in a mouse model, and neovascularization is the fundamental problem underlying ROP. We know that retinal vascular endothelium has high arachidonic acid content, much higher than elsewhere in the central nervous system. And as shown by this team, low arachidonic acid levels are associated with an increased risk of ROP. So the study involved 206 babies less than 28 weeks. The intervention arm received arachidonic acid at 100 milligrams and DHA at 50 milligram per kilogram per day from day 3 until term. The control group actually received no supplement at all, so technically the study wasn't totally blinded. The primary outcome was severe ROP, determined as stage 3 ROP and or zone 1 ROP. And as the clinicians will know, this is potentially blinding eye disease. What they showed was a significant reduction, both clinically and statistically, a 50% reduction in the incidence of severe ROP. They found no difference in death, BPD, IVH, NEC, sepsis, or serious adverse events, arguing for safety. The benefits of the intervention were pretty much confined to babies less than 27 weeks. In fact, I only saw one baby in the 27-week cohort who developed severe ROP. But within the 27-week group, there was a suggestion of increased morbidity related to intervention. And in particular, there was a suggestion of an increase in the incidence of BPD, though, as you can see there, the numbers are very small. Now, this is clearly an important study. I think all the clinicians would agree that that reduction in the incidence of potentially blinding eye disease is significant. And if it can be achieved by dietary intervention in a very small group of babies, then that sounds fairly promising. So in summary, if we were to consider the evidence to date regarding high-dose DHA and/or arachidonic acid on preterm outcomes, for BPD, we'd have to say that high-dose DHA appears to be related to possible harm. With high-dose DHA and arachidonic acid, I think it's unclear. Clearly, the combined DHA and arachidonic acid intervention in the Donna mega study, that's the Swedish study we just spoke of, that needs to be validated with a bigger study, which would serve to confirm the primary observation, but it would also serve to address issues of possible harm. With respect to ROP, no signal with respect to high-dose DHA except for the small Mexican study. And with respect to high-dose DHA and arachidonic acid, you'd have to say that that looks promising, but needs further study, needs to be consolidated with a big randomized controlled trial. Other outcomes, high DHA, pretty certain no effect. High-dose DHA and arachidonic acid, we really don't know because we really don't have a big enough study to address that question. Finally, with respect to developmental outcome, I think the results of the Hendrickson study and the results of the results of DINO clearly suggest short-term benefits, but the longer-term impacts of these interventions, again, is not quite clear at this point in time. So that, in my opinion, is the current state of the art. I haven't talked about intravenous lipids because there just wasn't enough time. But I think that the likelihood that they have a significant impact is small. So in closing, much of the material I mentioned today and all the material from our unit reflects the energies of our team. Key players of whom are Maria McCready, who's the lipid biochemist, Carmel Collins, who ran the DINO Trial, Tom Sullivan, who's our statistician, obviously the team there, plus our huge team in our trials network, and of course the babies and their parents, the babies for being involved and the parents for giving up so much of their time and energies to facilitate our follow-up programs. Thank you very much.